Having a good day so far. A good morning to folks that are on the West Coast. I know we got quite a few folks from California joining and from all around the country. Welcome, everyone. My name is Shelley Wiseman. I am with the Center on Addiction and Public Policy at the O'Neill Institute for National and Global Health Law, which is at Georgetown University Law Center in Washington, D.C. The topic of today's webinar is building the substance use disorder workforce of the future. I am honored to join a group of people that I deeply respect for this virtual event, and thank you everybody for taking time out of your day. We have folks from, like I said, all around the country and who are working in all different areas of the field. So thank you everyone for joining. We're going to begin with an overview of the current state of substance use disorder in the US and how that ties into the workforce picture. And then we're going to do a walkthrough of a new piece of model state legislation that can serve as a template for states in addressing this issue. We will then have a panel discussion with a wonderful group of leaders and innovators who I'm so excited to hear from today. First, however, I'm going to introduce Sarah Kelsey, who is the co-founder and CEO of the Legislative Analysis and Public Policy Association, which is an organization funded by the White House Office of National Drug Control Policy to develop model state legislation on substance use disorder and drug policy. We have worked with LAPA to develop a number of model laws on a variety of topics, including the model law that we're going to be discussing today on the SUD workforce. LAPA is a tremendous resource, and we've asked Sarah to share a little bit about the organization and the resources that they have available. So I'll turn it over to you, Sarah.
Thanks, Shelley. Welcome, everyone. Thank you for inviting me to be a part of what I know is going to be a really engaging conversation about what is becoming an increasingly important topic. As Shelley said, I'm Sarah Kelsey. I'm with the Legislative Analysis and Public Policy Association, or what we like to call LAPA. And for anyone who isn't familiar with us, we're a 501c3 nonpartisan organization, and as Shelley said, primarily funded by the Office of National Drug Control Policy. And our primary mission is to conduct legal and legislative research and analysis and draft model legislation, generally in the areas of public safety and health, substance use disorder, and the criminal justice system, kind of where those topics intersect. We draft on a pretty wide variety of topics. A couple of our more recently published models cover things like the collateral consequences of conviction, SUD parity and insurance, Medicaid reentry waivers. We also update models from time to time if the landscape has changed substantially in an area. Overdose reversal agents, naloxone is a model we recently updated. We've recently updated our MAT in correctional settings, which is a project we worked on with Shelley and her team. Some of the models that might be interesting to this particular audience are the expanding access to peer recovery support services, something that might come up in the conversation today, recovery ready workplaces, maybe the Opioid Litigation Proceeds Act, since those monies perhaps is something that could be used to build the workforce. In addition to models, we also publish 50 state summaries and fact sheets, which are a shorter resource. I encourage everyone to go look at those resources on our website. And if you have a topic that you might be interested in seeing a fact sheet on, or maybe even seeing a model on, please reach out to us. I will make sure that our website is in the chat, or you can reach out to me in the contact information that I'm sure we'll get out there somewhere. And finally, I would encourage everyone to check out another great resource, very pertinent to today's topic, which is available on SAMHSA's website, which is the Behavioral Health Career Navigator. And if anyone is not familiar with this tool, it's for those that are interested in careers in behavioral health. And it's basically a state by state guide that lists the licensing and certification requirements for a very wide variety of careers in the behavioral health field. So for people looking to get started, this is a really great resource, and I can put that information in the chat as well. So thank you again, Shelley. I'm really looking forward to the conversation today. And with that, I will turn it back over to you. Thanks.
Great. Thank you so much, Sarah. And thanks for all the work that LAPA does on these issues. And we will be taking kind of Q&A throughout the panel discussion. So I encourage folks, if you have questions and you don't want to forget, just put them in the Q&A function of the webinar, and our wonderful moderator, Donald McDonald, will incorporate them into the discussion. And this event is being recorded, and the slides that I'm about to share will be shared with folks after in an email. So we can definitely make sure everybody has access to that, and it'll be up on our website after we get it captioned. All right, so let's get started on our kind of level set overview, and then we'll talk about the model law, and then we'll get into our panel discussion. So you can give Cody, if you can go ahead and share the slides. Okay, great. All right, I'm gonna put all of a sudden I needed reading glasses a year ago. I don't know if anyone can relate to that. So again, my name is Shelley Wiseman. I'm with the Center on Addiction and Public Policy. So for those of you who aren't familiar with us, we are basically a health policy think tank housed at Georgetown Law School. And we work on strategies for federal, state, and local government to translate science and evidence into actionable public policy. So these model laws that we work on are one tool that we use to do that. We'll go to the next slide. We also have a number of leadership development programs. We have a Master of Science in Addiction Policy and Practice, which is a one-year interdisciplinary program on addiction policy. We are in our 4th cohort and are about to graduate them in the summer, and are going to welcome our 5th cohort this summer. And we have a number of other initiatives like our Recovery Policy Collaborative, which is a network of experts with lived experience in addiction and recovery who work in government and policy. All right, next slide, please. Okay, so just, an overview of information that many of you surely have committed to memory at this point. And of course, it goes without saying that the impact of substance use disorder is felt broadly across the nation. Over 1 million people have been lost to overdose since the year 2000. We had a few years in a row where the death toll exceeded 100,000 deaths. And more people die of alcohol-related issues than overdose. I think 178,000 was the last number I saw a year. So we're really in a beyond a crisis, right? An epidemic. And according to some recent data, almost 50 million Americans meet the criteria for substance use disorder, but less than a quarter receive any treatment. This is up actually from in a positive direction from the historic number of about 10 to 12% who need treatment but don't receive it. But there's still a long way to go. And when you kind of dig into those data, you see that there are significant racial disparities, significant geographic disparities related to who actually receive treatment. People all across the country of all backgrounds face significant barriers to accessing treatment, but especially communities of color. For example, on average, it takes Black Americans about 5 years longer to access treatment. And the numbers on access to treatment, as we know, don't always reflect quality of treatment or what the outcomes of that treatment is. And it also doesn't reflect all the other things that we know help people stay on a path to recovery, like social support, social determinants of health. We know that the impact of substance use disorder is wide ranging. It affects parents, siblings, children, friends, communities. A recent study by RAND found that more than 40% of Americans know someone who died of an overdose, and the impact on children is perhaps the most significant. Another study found that more than 300,000 children have lost a parent to overdose in the 10-year period of time between 2011 and 2021. And of course, we know that number has increased now. And a study by SAMHSA found that 12% of children, that's 8.7 million children, live in a household with at least one parent with substance use disorder. So, we really have an access challenge and an impact challenge, right? And of course, this full impact reverberates across communities and across the economy. So we'll go on to the next slide. Government at all levels has made a concerted effort to reduce overdose deaths and to increase access to treatment. And this is starting to work. In 2023 and 2024, the US saw a decrease in overdose fatalities. In 23, it was the first decrease since a slight decrease in 2018. However, this decrease was not the same for all communities. As you can see in the first graph, the overdose death rate for Black and American Indian and Alaska Native communities has increased at an alarming rate in recent years. White deaths also increased, but at a slower rate, and then began to decrease beginning in 2022, while deaths of other races and ethnicities continued to increase for the next few years, but at a slower rate. So for example, in 2023, this is the second graph, overdose deaths fell approximately 3% nationally, but that was white deaths that decreased almost 6%, but deaths in Black and Indigenous communities continued to climb. In 2024, overdose deaths decreased by, I think it was 24 or 25%, and this did include a decrease across the board for all races. So what we can see is that our interventions are working, but they're not necessarily working in the same way for all communities, in particular for communities of color. Next slide, please. So I'm going to talk about all the stuff going on in this slide, but the first thing I wanted to say before I do that is that, despite this, there is hope. I'm a person in long-term recovery personally. I got connected to treatment and recovery supports, which not only saved my life, but really set me up to thrive. I do this work like so many of you who are listening in and joining us today because I believe that everybody deserves the same chance that I had. And not everybody with substance use disorder finds recovery through treatment. When someone with a substance use disorder gets help, treatment might be part of their journey, or they might find intervention and support in other ways, like their primary care doctor or a recovery community or a harm reduction organization or community. Some never engage with professionals at all, but many do. And so that's a bit about what we're talking about today is, the world of folks that are involved in these interventions. And it's a wide range of people. Primary care physicians, OBGYNs, addiction medicine physicians, psychiatrists, psychologists, nurses at all levels, social workers, counselors, care managers, peer support professionals, people working in harm reduction settings, in recovery community organizations, and more. And in a wide range of settings too, right? Could be in inpatient settings, outpatient, carceral settings, courts. And we're also talking about the administrators and back office support that as we move increasingly into a kind of more complex payment environment, we need more and more of. And you look, the next kind of circle out even more people when we're looking at all the different systems that substance use disorder might touch. Pharmacists, people working in housing, child welfare system, the criminal legal system. So, the takeaway from this slide here is that there's not enough people to do the job. And if we keep doing what we're doing, there's not going to be enough. For example, as of 2023, there were only approximately 4,300 addiction medicine physicians in the US, and that's compared to about 22,000 cardiologists. So it's, a small field and needs to grow. HRSA, the Health Research and Services Administration, tracks the SUD workforce and projects how the kind of current trends are going to impact the adequacy of the workforce over a long period of time. And so, for example, the supply of addiction counselors is projected to fall by 28%, while the demand is projected to increase by 58%. So without any intervention, this means that the addiction counselor pool will not be adequate, right? It will only be adequate really to treat less than half of people with substance use disorder. So we need more of everybody. We need more diversity, particular racial, ethnic, and geographic diversity. Um, and we, just kind of digging into that for a minute, we know that from the research that racial or ethnic concordance between patients and providers is associated with improved treatment outcomes. But when we look at the breakdown of addiction counselors, for example, 63% of addiction counselors are white and only 11% are Black. 2% of psychiatrists are Black. So Black, Hispanic, and Indigenous persons are underrepresented in the workforce pool of physicians, of physician assistants, nurse practitioners, psychologists. And this is really important because, as we just saw, Black folks and Indigenous folks are the ones who are dying at a higher rate. And if we're really going to get a handle on this, we have to think differently about how services are delivered, about the types of interventions and supports that are available, about who is delivering these services, and how do we get people to come into these jobs and stay in these jobs, right? Because these jobs are hard. I've worked out there in the field. I venture to say that most everybody listening either is out there day-to-day working or has, and these jobs are hard jobs, and they're only getting harder as people present with more complex needs. And the result is a staggering turnover rate that is more than twice of the national workforce. So in our field, the turnover rate is 32%. Nationally, the workforce turnover rate is 13.5%. Right? So when we dig into these numbers, we really are seeing some issues. Next slide, please. And again, this is not a new issue. This is something that states and providers and communities have been grappling with for a long time. The federal government and states have been thinking about these issues and taking action on these issues for many years. This is a list of just some examples of initiatives that have been done to try to address this. I'm not going to read them off, but I'll just highlight here, for example, many states have added different types of roles, professional roles about who can bill Medicaid, like peer support specialists and community health workers, harm reduction work. So let's move on to the next slide in the interest of time here. And these initiatives have really helped to reduce overdose deaths. But as I think, are going to hear about, there's a lot of uncertainty right now about federal funding and policy priorities. We've seen significant cuts to staffing at SAMHSA. It's unclear how this is going to impact the rollout of block grant and other grant funding. We know that Congress is looking at cutting $880 billion from Medicaid. Unclear how that is going to roll out and when. So, while the workforce issue is not a new problem for states, we're in a new landscape, and states have been considering how to build on the good work that's already been done. You can see some examples here from 3 states, but many other states have done a lot of work on these issues. So that brings us to our model law. Here at Georgetown, the next slide, we worked with the White House ONDCP, with LAPA, with a wide range of experts, including providers, people with lived and living experience, to develop a comprehensive model law on the SUD workforce. So at a high level, this law establishes an independent commission to do the work of looking at what's the current state of the workforce in that state, a landscape review, a needs assessment, and then come up with a strategy that's going to be implemented over a 10-year period of time with immediate actions, short-term, medium-term, and long-term goals and objectives. And the law outlines a detailed list of strategies and actions that this independent commission should consider. Reevaluating pathways to licensure in a way that's guided by research, for example, paying for supervision, developing a pipeline with community colleges, universities, and historically Black and minority serving colleges and universities, reducing the administrative burden on the workforce, which is something we heard over and over again as we talked with folks all around the country who are working in this field. And of course, salaries. We have to pay people to do these jobs. All of these and more, I'm going to kind of highlight additional ones. And then following the strategy, this piece of legislation outlines an implementation and technical assistance strategy, basically, to establish a new cabinet level office of SUD workforce and a technical assistance center to help both job seekers and providers to implement. And some accountability built in, a public dashboard, public meetings, input and engagement from the public, and identifying and prioritizing action items that might require additional legislation or rulemaking, coordination with multiple agencies, collaboration with higher education, or really doing a review of the way things currently are and identifying anything that might currently be kind of harming the goals or the vision and addressing that. Next slide, please. The model law prioritizes 5 areas. I'm going to go over each of these quickly and talk a little bit about what the needs assessment's looking at and then what the strategy will incorporate. But in the interest of time, I'm going to kind of move through these quickly. Again, you can check out the full model law, which we can put in the chat if it isn't already, and the slides will be available. So next slide, please. Starting with increasing the workforce to meet the needs of the people that are being served. So strategies include things like recruiting, partnerships, retention initiatives. One thing, for example, that we saw is loan repayment. While it can be a positive strategy, it's not necessarily enough. People need the money up front, so having the strategy kind of look at that issue. That's one example. Next slide, please. Again, a pipeline of workers, incentives, addressing barriers to licensure, certification, and credentialing, addressing burnout, ensuring adequate and continuous training, and of course, salary and benefits. Next slide. Looking at administrative efficiency, looking at technology, building the infrastructure of the workforce, and financial assistance and technical assistance for treatment providers and for non-clinical settings. I think in a lot of states, including one state where I worked in government for a long time, it was like initiative fatigue from the provider community. And really getting a handle on helping providers to meet the moment with resources, funding and resources and support. Next slide, please. Uh-oh. Let's see. Can you go back one? Sorry about that. Back one more. Integrated approaches and integrative approaches. So looking at cross systems approaches. The SUD workforce is not the only workforce that has challenges in any state. This is an issue across the board in health and human services and in other fields as well. So maximizing initiatives that are cross systems, economic development and labor, really taking SUD out of this kind of boutique issue over here and integrating it with everything else going on in the state. And then finally, leveraging, next slide, leveraging funding and financing mechanisms, looking at braiding funding and maximizing insurance coverage, including in Medicaid. So next slide, please. These are a bunch of resources that I've mentioned. Again, these slides are going to go out to everyone. And final slide, which the message is, you know, there's a lot of work to do, but a lot of great work has been done and is being done. If we start now kind of in our new environment to really look ahead, where do we want to be? You know, I talk a lot about the settlement dollars. We don't have to, we can stop sharing the slides. Settlement dollars, and kind of the structure for how those are spent. And, you know, really to start thinking about like, where do we want to be at the end of 18 years? You know, where do we want to be in our system? And thinking now about what that vision could look like. So, with all of that backdrop, I will stop talking and I'm going to turn it over to a dear friend and colleague, Donald McDonald, who's going to introduce himself and our panel, and we'll get into it. And I'll remind folks to put any questions in the Q&A function, and looking forward to a great discussion. Thank you.
Thank you, Shelley. That was delightful, and it's been a delight to participate in this process of trying to encourage some model policy solutions for some very wicked problems that we have around the country. Policy can help, and you've done great work. You and the folks at LAPA have been tremendous in that regard. The great questions coming up in the Q&A, so please continue to put those in. I hope to address some of those live in this process. My name is Donald McDonald. I'm a person thriving in sustained recovery from severe mental and substance use disorders. About 6 years into my personal recovery, I decided to get into the workforce. I got into essentially a non-clinical, peer-based role at an opioid treatment program. And then I moved into a long-term residential social model, peer-driven program where I became inspired by social workers working there to pursue some higher education. I thought I would become a clinician for a while, so I got a license and had some splendid experience in settings like drug treatment courts, so outpatient behavioral health treatment settings, on an ACT team doing some in-home therapy for folks experiencing serious and persistent mental illness. But then, you know, I got bit with the bug for doing some macro stuff, some macro peer support. So we founded a recovery community organization in my home state, and I got a great gig there out of college, and then moved to my Addiction Professional Trade Association, one of the affiliates of Terrence's organization, NADAC affiliate in North Carolina, and how important it is to influence the education of our entire continuum of behavioral health professionals, peers, clinicians, researchers, prescribers, and the like. And for the last 6 years, I have been providing training and technical assistance in rural communities through this administration's generous investment in helping to try to fill the gaps in rural communities through expanding the behavioral health workforce from peers to clinicians to prescribers, and expanding the scope and the accessibility of the entire continuum of care at all levels of prevention, treatment access, and recovery support services. And recovery support services has kind of turned into my deep dive. I identify as a peer recovery coach. I do not have a clinical license, and I consider myself a macro peer supporter. So in answer to some of the questions out there about the sustainable peer workforce, you're on it. It's been considered an entry level and an ancillary extension workforce for some time. Yet there has been florid descriptions of how critical and integral and amazing this workforce is. So in our communities, we have to ensure that our budgets reflect are commensurate with that florid language, and also our place at the table. Someone else mentioned that we are on teams that are considered equal. We have our prescribers, we have our clinicians, and we have our peers, all with our specialization, all on a first name basis at the table. No hierarchy on the treatment team would be an important thing. And I've also seen some amazing investments through this rural community investment. I'm seeing more peers getting included. I'm seeing folks pay them living wages and provide opportunities for advancement. I'm seeing peers becoming project managers, supervisors, and starting to organize their community's entire peer workforce to have opportunity and meaningful inclusion. And also, it's important. I have learned across the country that inclusion of the peer workforce not only is important to the continuum of care, but it is also has a positive influence on the organization and on the system as well, from colleagues to the organizational culture and the leadership. So I think I've gotten a few of those answers. Now I'd love for, that's my skin in the game. So I'd love to have my colleagues, Dee and Terrence, introduce themselves and why they're here, and then we'll get into some questions.
I can go first if that's okay with Terrence. My name is Deirdre Calvert, and I do go by D. And I am I'm an LICSW and MSW, and I'm also a person in long-term recovery. So, and that's really important to what I bring to the field in my role working for the state of Massachusetts. I'm really one of the first clinicians and person in long-term recovery. We had a wonderful person in long-term recovery before me, but not a clinician. So I'm bringing both of those lenses in. My experience before coming to the state pretty much worked in every single level of care, from opiate treatment programs, residential facilities. I also was on a PAC team or ACT team, and in every aspect of the continuum. 6 years ago, I was lucky enough to be asked to take this role at a macro level. I'm very much a clinician at heart. So always come looking at our policies and our investments from a clinical lens and from somebody who's actually spent 30 years in the field doing the actual work. So that's a little bit about me.
Thank you.
Thank you, Dee, and good afternoon, everyone, or good morning, depending on where you are. I am Terrence Walton. I'm the Executive Director and CEO of NADAC, the Association for Addiction Professionals. I'm looking forward to telling you a little bit more about NADAC in just a moment. So, to understand sort of, why I sit here, why I'm in this space, why this matters to me, I need to first say that, there are two really big components of my life, two really big things that matter. First and foremost is my family, being sure they are well and taken care of. So whether I'm in my home office like I am now, I see pictures of them nearby. When I'm at my office in Alexandria, they're nearby on my phone. That's what matters most. As long as that's taken care of, then my life, my career of more than 30 years has been fully dedicated to helping people break free from addiction. And for most of that time, it has involved helping people who are helping people break free. I'm a longtime ally of people in or seeking long-term recovery. And I won't say today, I won't take time today talking about sort of why that matters to me. It took me a while to figure out why I wanted to be an addiction counselor. And I was a counselor for several years, and why I wanted to run addiction programs, and why I cared so much about drug treatment courts, and why I sit here now as the executive director. It took me a while to figure out why that mattered so much to me. But it is I guess the quickest way to say it is my calling. I understand why I'm here, and there is no greater gift, and to both the giver and the receiver, being able to walk alongside a person on that road from addiction to recovery. So I'm really happy, glad to see so many of you here. Thank you to the Neal Institute and LAPA for both the work on the model legislation and your efforts to bring us together today.
Thanks, Terrence. That was wonderful. And thanks for identifying as a recovery ally. That is a member of the recovery community. And I personally would be lost without the allies. And one of my greatest allies in my career was my state's SSA, Flo Stein. She took an interest in my career early on, and our state ended up becoming one of the leaders in investing prevention, treatment, and recovery block grant dollars in supporting recovery community organization development. So Dee, let folks know what is an SSA and kind of what role y'all can play, each state's in helping to enhance an adequate and sustainable workforce.
Yeah, sure. So an SSA is a single state authority, and we are federally designated, each state. Um, so each state has an SSA or a single state authority, and we really are the primary agency. So it's not just me. I am the single state authority, but I really look at our Bureau of Substance Addiction Services, BSAS. That's under Department of Public Health where I am. We're responsible for planning and implementing and overseeing all of the publicly funded dollars, state and federally. We are, we are really important in making sure that there's strategic allocation, that we make policy development a priority, that we do advocacy. And SSAs are really in a unique position to ensure that the SUD workforce is well equipped, well supported, and empowered to really meet the needs of individuals and communities affected by substance use. And it's not just people in recovery, but it's we're true believers that all people have dignity and value in their lives. So people who have chosen to continue using, if they just want to be less chaotic or something like that. So everybody is encouraged in this workforce to be part of it. People with lived and living experience are really the people that inform our work as SSA, and that includes family members as well. But that's a little bit about the SSA.
Right on. Thank you so much. In my capacity of training and technical assistance and helping to encourage the inclusion of peer-based workforce and its sustainability, I do try to let folks know that pathway to sustainability is get to know your SSA. So, and get to know your trade association. There was a question in the Q&A about whether or not this model law was SUD workforce specific or behavioral health workforce, which includes those specializing in substance use and mental health. And I did raise this question as a person who had an opportunity to review the draft model law. And the fact is, if we were to propose a model policy that address the gaps and needs within that whole workforce, that would be quite an elephant to eat in a couple bites. So, there is a substance use specific workforce. So there is a substance use specific critical need throughout our country right now. And speaking of that, addiction professional trade associations, it's worth checking it out to see if you can throw your lot in with your peers from around the country, whether you're a peer or a clinician or a prevention specialist or a researcher. Check out NADAC or your state's affiliate. So exactly, Terrence, what is NADAC? And what role can your members and your organization play in trying to improve access to an adequate and sustainable workforce?
Well, that's a great question, and I appreciate the discussion, the question about sort of whether this is about all of behavioral health, those of us who specialize in mental health services, and those of us who specialize in addiction. And later on, I'll talk about why that's a really important question and why it is really important to have opportunities like this to focus on those of us who specialize in addiction, prevention, treatment, harm reduction, and recovery. It really matters. They're not exactly the same. And that's who NADAC is. NADAC is a membership organization. We work very closely with organizations that are trade organizations that focus on the providers, the places where addiction professionals work. We support their work as well to help them function as well-functioning businesses. However, our primary focus is the men and women, the people who treat addiction, who help to prevent addiction, who help people along the road of recovery, who support recovery, who deliver harm reduction services, those who work in addiction studies programs. All of those are addiction professionals that we support. So a big part of that is what we're focusing on today. How to help develop and build that workforce. And that includes being sure they have the right tools, the right information, creating online forums for members so they can interact with each other and get some informal mentoring, venting, advice, a sense of community, even if they work far apart, even if they work in a small program or in private practice. They have access to more than 14,000 other members who are part of NADAC and our affiliates. We have affiliates in every state and in several countries, all with the same purpose: how we can equip, empower, and unite the workforce. I'll put a link in later to our website, so where we have hundreds of hours of resources that are free to everybody, actually, and free CEs for our members. Uh, we also do lots of advocacy, and we'll talk about some of that today, to try and help create the environment, the structure, the system, or influence the systems that can help addiction professionals do their job, and not have to take a vow of poverty, to be able to make a living, care for themselves and those who they're responsible for, but also do this work. None of us does this, Donald, as you know, and others. None of us does this, to get rich. None of us, are involved in any of this work, because we have a profit motive. But despite that, we do need to be able to make a living, and so our advocacy is about being sure that addiction counselors and other addiction professionals are able to be compensated for their work, be providers at the same levels as other behavioral health professionals, at least, and we work hard to do that. So I can talk more about it as we go forward. But NADAC is not the only membership organization, but we've been around for more than 50 years, and we certainly are the dominant voice for the addiction professionals, especially those that are not medical providers and not prescribers. They're our partners and friends, but we focus mostly on addiction professionals who don't focus as much on the bio part, but the psychosocial, spiritual, environmental elements of addiction and the long journey of recovery.
Right on. Thank you. You described a professional association nicely. I did spend some time as the association director trying to let folks know the difference between credentialing boards and professional association. One essentially to protect patients, clients, participants, and one to protect and empower us as a workforce. And I think it's a nice balance. Great. Let's move into some brass tacks, y'all. We have a current policy and funding environment that may be presenting some challenges for folks. Folks may be concerned about the future of their financing landscape. Folks are making probably some difficult choices about how they continue to offer services in the way that they have been. What do y'all recommend that states, providers, individuals can do now as contingency or to get ahead of any shifts in the policy and fiscal environment that may interrupt services or may cause more complications? I'm going to stop talking, but I think you smell what I'm stepping in.
Would you like me to start? So, this has been tough since January, right? It's been chaotic and uncertain and a little bit of whiplash. But I'm really, really grateful that I live in Massachusetts because we have taken steps to invest already. So regardless of what happens federally, hopefully the impact can be softened a little bit. And so I'm going to talk in depth a little bit later on about some of the specific strategies that really actually align with this model legislation. But some of the things that we're doing right now, and that is that our opiate remediation fund money, that is the pharmaceutical lawsuit money, every state calls it differently. But in Massachusetts, we call it ORF, Opiate Remediation and Recovery Fund. The first disbursement that we did was $15 million to tuition reimbursement to those who are in the SUD workforce in licensed BSAS, Bureau of Substance Addiction Services. So that was the first thing that we did, is we made a $15 million investment right off the bat. The state has continued that with our mass repay, which is behavioral health professionals, including SUD, can get $50,000 reimbursed for their bachelor's or their master's degree, and $25,000 for their associate's degree. That is great. I think that Shelley also laid out that that is great, but, and I should say, retention is our biggest problem, right? It's retention. Somebody told me the other day that we can't hire our way out of this because we're not doing enough to do retention for the people that we have. There's great recruiting strategies, but we really need to work on our retention strategies, and that just includes like the lack of supervision, the lack of mentoring, lack of supports for individuals in all levels of care that are just, that are really being problematic. As a clinician who worked so long in the field, it was the first thing that we got rid of when we needed to increase our census was the staff was stop doing supervision, put a participant, a patient, client, whatever you call your person, in that. And so then the staff wasn't getting supervision. We also put the most green people usually in like the least supervised shifts. So they're working 11 to 7 or 3 to 11, where they don't actually have the support that's needed. So those are some of the things that we're seeing. Shelley also mentioned, that a retention rate in Massachusetts. We have a 50% turnover rate every 2 years based on our license data, which is how we collect data every 2 years, and that is really problematic. And so again, it's not a hiring problem; it's a retention problem. And we have and through another survey that we did, like more than half of our workforce has 4 or fewer years of experience. So we have a really green field, right? And again, our salaries are too low. We have to pay people a living wage. We have to remember that these individuals are critical to our to life-saving interventions that we do for folks. And we have to pay people a living wage. So I'll stop there, and I'm going to go into more detail about some of those things, but I'll just stop there on what Massachusetts is doing.
Brilliant. Thank you so much. And the retention of workforce it includes the peer-based workforce as well.
Mhm.
And as I've participated in, you know, generously funded initiatives from this administration to expand the entire workforce, including the peer-based workforce, I am seeing folks begin to see their retention issues and begin paying peers more, offering more quality supervision, and offering opportunities for folks to move up into different career ladder rungs. I know Terrence Nadex getting in on that. I'm super excited about that. I was the director of our affiliate when we first included peers back in 2017, and it kind of remained considered an entry level position, but now y'all are doing something to remedy that along with your splendid national certification. But anyway, I just wanted to answer that question specific to peers. Terrence, do you have an answer for what folks can do for themselves? And I know y'all put out something recently.
Well, listen, there's a needless to say quite a bit going on in this space, and if we were having this discussion at a different point in time, if we were having this discussion in November, October, I'd be talking about NADEX partnering with our national partners to get increases in key areas, things that help to ensure that people who need help can get it, that they have. I'd be talking about a number of the programs. I'd be talking about increasing coverage, but we're in sort of a different posture. And so NADEC is a 501c6. We have a 501c3 foundation, but the organization itself is a 501c6, which means that we can lobby. We don't have to pretend that we're only educating legislators. We have a government relations firm that helps to promote policies, legislation that is favorable to people living with addiction and those who are helping them. And so at this point, we are really trying to hold the ground, that there are all kinds of possible reductions. You heard about some of those in in the beginning. And one of the things we released a couple of weeks ago was a urgent appeal, or urgent call to our 100,000 folks on our email list to help us prevent reductions in Medicaid. You heard that reference earlier, the possibility of $800,000, $800 million. I wish it was about $800 million in Medicaid cuts, potential Medicaid cuts that can greatly impact our ability to people's ability to receive the help that we need. That's a great concern. The possibility that Medicaid could become a state block grant, and reductions that are tied to that is also a possible an area of considerable concern. And so we have been working to mobilize our workforce to be sure that they are letting their legislators in Washington know the possible impact of those kinds of cuts. We're also concerned about other things that are very much tied to developing the addiction, the SUD services workforce, and is, for instance, the loan repayment programs that were mentioned earlier. We have supported an expansion of the STAR loan repayment program that actually that adds to the loan repayment program a scholarship program. Right now, we are hopeful that we can help to maintain the current HRSA funded loan repayment programs, which opens doors for individuals to get bachelor's degrees and master's degrees. That's important. There are also other fellowship programs that support addiction counselors funded by SAMHSA that help those who have bachelor's degrees get master's degrees, which puts them in the range where they can become licensed in many cases and get additional reimbursement. So these are important. I think what's really important is at this point, this is advocacy. This is the point when Congress is making decisions that if we can prevent, harmful reductions, it's better. There are also other challenges we'll talk about later in terms of being sure we can achieve a diverse workforce. That matters as well. But the current challenge, of course, is being sure that people get coverage, and therefore that's where our focus is right now.
Right on. Thank you so much. Y'all are doing a lot, and I think I may need to re-up my membership. I did let it lapse, Terrence. I got to be straight with you. Yeah. All right. Dee, anything from this model policy that stands out, tactics, or anything else you want to talk about that Massachusetts is leading the way on in this area?
Yeah, I was really excited to see this model legislation because, to be honest, we're doing so much already. And again, it makes me incredibly proud to be in Massachusetts. One of the things that we have done is we pay supervisors. So this was an initiative that was started by our state where independently licensed clinicians, an LICSW like myself or an LMHC, could sign up to be a supervisor to help supervise the behavioral health workforce, because many people go into a program and they don't have a supervisor, so it inhibits them. They don't want to work there. They don't have, because they're not able to get their license. So we actually, the state has implemented that. In Massachusetts, we also have a license, a LADAC, which is our licensed alcohol and drug counselor license, that's specific to Massachusetts, and we waived starting in 2022 all of the fees for that. That is initial fees and renewals, right? So because we knew that that was a barrier to people continuing their LADAC. And since we've done that in the 3 years, we've grown from 120 LADACs a year to 140. And those LADACs can become a LADAC 1 or 2. So depending on their education, a LADAC 1 can independently bill in Massachusetts Medicaid, right? And so that is really important. So one of the cool things that we've done is we're partnering with our schools of social work, bachelor's level and master's level, to have individuals meet all of the requirements for a LADAC while they are in school. So when they graduate, they actually have an independent license that they can actually bill for. So for an undergrad, it would be a LADAC 2, right? That can't actually bill, but it's still a license, and it's got a lot of desirability. But if you're in the master's program, you're going to hopefully leave with this independent license, which automatically makes you very marketable in our system. We also know that, and this happened with me as I got into the field of substance use when I was placed as a master's level intern, right? And I loved it, but I stayed with it. And we find that many people actually stay with the internship that they're with. So if we can pay people for their internships, which is something that we're doing here in Massachusetts for BSAS, it drives me bonkers that we think it's adequate to mandate that somebody works for free 20 to 30 hours a week to get their master's level degree, right, for free while they're in school at a college that's probably in Massachusetts $170,000, right? So for tuition. So we do pay for internships. And so we have 2-year grants to 8 organizations that have served 230 interns. And 20% of them were hired as permanent employees once they were done after that first year of that program. So that is another really cool thing that we're doing that's really in line with the model legislation. The other thing that we do here that we have is we do a second level query. So especially for that peer workforce who may have a table A felony offense in Massachusetts, we require each program who wants to hire somebody to do a second level query review where somebody can absolutely get hired even though they might have a felony conviction. And there's a lot of actual steps. It's, I'm making it super simple for this, but I sit on that review board. And so we have somebody who has been in the carceral setting for 9 years, but they got many, certifications. They found recovery. They've left and went to, and became a recovery coach. A lot of times that felony conviction can inhibit them from actually working in the workforce. And so we have this what we call a second level core review, which has been unbelievable. Another thing that we're doing here in Massachusetts matches with that model legislation is we have a recovery education collaborative, which was formed in 2022, which is really a technical training and technical assistance for recovery coaches, recovery coach supervisors, hiring programs, and others. And that has been like amazing. And that also kind of dovetails with our Black and Latina addiction education, which is specific to the Black and Latina communities, which we know is an incredible need within our field. We need to have diversity. We need to have people that don't look like me taking care of people, in our communities. As Shelley also said, we have been really grateful and profoundly humbled that we have we're seeing a decrease last year and an even bigger decrease from 2024 in our overdose deaths. But the groups of people who are continuing to rise are Black individuals, Black men over 50, are Native American and Alaskan Indian individuals. That is problematic, right? And so we need people that actually look and are culturally specific. And then the last thing I'll talk about is we have a careers of substance website, which includes a dashboard, which is another thing that really aligns well with this, where it's like a one-stop shopping in Massachusetts for addiction recovery professionals can go in and see what's the legislation out there, what are some funding opportunities, what are some job opportunities, what are some trainings that we offer for free at BSAS. So I'll stop there.
Wow, that's brilliant. I almost could consider moving up yonder, but it's too cold. I'm a Carolina boy. And I can definitely identify with the paid internship. I was an underpaid peer-based worker going to grad school and engaging in clinical rotations, and paying a whole bunch of money from student loans. So that would have been super helpful for me and a lot less stress on my wife. Terrence, what do you identify with in this model law, and what have you seen working?
Well, a couple of things. I want to say, first of all, that I can't remember early when I was talking whether I talked about the potential Medicare cuts that are now being, a part of the budget reconciliation bill. I can't remember whether I said million or billion. I wish 800 million was the correct answer. If I said million, I should have said $800 billion in cuts. And it's impossible to achieve that level of cuts and not directly impact the services that people receive. So that's why this is such a big deal, and why we have issued a call to action. So listen, I think I love a lot of what Dee said there. I think that those are the kinds of things we're seeing in some places. I think the fact that in across the country that peer professionals are recognized as a valuable part of the workforce is going to help close the gap that we're seeing between those who need services and people who are there to help provide those services and support. That really matters. I also appreciate the focus in the model legislation in considering behavioral health equity and looking at the differences in the workforce compared to those they're serving, and that really matters, and that's going to become especially important based currently on the executive orders that focus on sort of recharacterize efforts to look at diversity and achieve an equitable workforce as discrimination. And you referenced, Donald, one of the communications we released. I think it was last week to the field, where I clarified that NADAC reaffirms our unwavering commitment to merit-based opportunities, culture responsive and sensitive counseling interventions, equitable access to effective treatment, and a qualified, committed, and diverse behavioral workforce, even though we'll likely have to pay for that without government funds. But Shelley's presentation describes why we have no choice but to do that. Her earlier remarks, where she described sort of those who are underserved and where the biggest gaps exist among the professional population, that requires that an organization like NADAC and some out there take robust actions to try and be sure we are recruiting new people from all communities to become a part of this workforce. And we're seeing that happening. We're seeing that happening through some of the fellowships programs, through the loan repayment programs, through the efforts to recruit at every level and every community. And more of that has got to continue. I said earlier that I was going to try to make it clearer why it really is important that we understand that while we're all behavioral health professionals, those of us who specialize in addiction, recovery, and related issues, what really matters is that we are distinct, and that's because based through training and credentialing, and in some cases life experience, we're uniquely qualified to treat this issue. My wife works from home just as I do a lot of the time, and she's in the office right next door. She's an LICSW who is very experienced, very good at her work. However, she acknowledges that in her MSW program, she never had a single course related to addiction, not one. And so however, based on her independent clinical license, she can treat anything that's in DSM-5, including SUD, including substance disorder, though she feels fully unqualified to do so. And so it really is important that we get young people who are in high school who want to become addiction professionals. And NADAC tries to help with this in several areas by focusing on those in higher education and elsewhere to consider addiction studies and careers helping people navigate recovery. I can talk more about that if we have more time, but it's really important that we understand the specialty among behavioral health professionals of those of us who focus on this issue, this aspect of the behavior.
Thank you so much for that. so much to unpack. And folks, please read this model law and know that it's a model, it's a proposed model piece, but I love it because it's so filled with practical tactics. It has a lot of recommendations within it. It starts with a participatory process of all stakeholders coming to the table, an assessment of needs, a 10-year plan with immediate, intermediate, and long-term goals, transparency with the community, with a dashboard and public meetings, and a deep dive also into engagement and retention practices, tactics, ranging from opportunities for mutual aid for the workforce to the waiving of fees. I think it's just it's a heck of a piece, and that's what I like about it. And it also contains a nod to technology and no discussion about workforce adequacy is complete without talking about technology. This administration has made just robust investments in expanding the technological access of folks in rural communities through closing the device gap, closing the broadband gap, and also with policy extensions for folks to engage in digital treatments and pharmacotherapies. Do y'all have anything to say about the digital potential digital solutions that we could work with here from either your state or nationally?
Well, we're certainly seeing one way to expand access, especially to those in rural communities, is the increased use of teletherapy and related approaches. There is, for instance, a program I believe in Montana where there isn't an individual there isn't a physician within miles and miles who can help to support people who need medications for addiction treatment. And they have found a way to be able for a great deal of the physician's work to be done remotely to allow an increase in access. And those kinds of things matter. So that has great potential for increasing access. And in some cases, individuals who are reluctant to enter treatment because of concerns about walking into a place may find that they are better able to receive services if they can do so remotely. So that matters. And then finally, I think that to the extent that providers and places where addiction professionals work are able to invest in it, being able to help a workforce that's not large enough work more efficiently is important. That is a method of sort of expanding us by allowing us to be able to work more efficiently, use technology to help us do our job so we can free up other time and energy to actually working directly to help people.
Right on. Dee, do you have anything to add to the tech talk?
Well, we lean in, absolutely lean in to telehealth because we know that it can be overwhelming or it just inaccessible for folks to get to treatment providers. One thing I always like to bring up is that the federal waivers that happen for opiate treatment programs during COVID increased retention, increased people attending their clinical appointments. It increased actual census because people were allowed to actually have a life. And so we had a lot of lessons learned. We had more people on take homes, more people who, like I said, were adherent to whatever the clinical standards were, and it was unbelievable. So we really have reached out to that. We've also been lucky enough to work with Tufts University about a geographic kind of overlay of where decedents were and where an OTP was and how far and how long it took for somebody to walk, take a bus, take a car, and what that access is. And this is a very small state that has, I think, 50-ish opiate treatment programs in our state, and we still have, drive times of hours, and walk times. So again, really leaning hard into that, we have a whole rural section in Western Mass. So ensuring that is something that we lean into.
Right on, right on. So, we agree that there is a need to find ways to enhance the behavioral health workforce to meet the rising behavioral health need, that there are policy solutions. And I just want to remind folks that it's not just statutory policy solution. It could be your own organizational policies and procedures that may be a barrier to your professionals working to the fullness of their potential, or retaining your participants, clients, patients as well. So taking a look at your policies and procedures, maybe inviting some folks to come in and cast some separate eyes on those as well, to see if you got a blind spot, because we all kind of do. I wanted to say one more thing about comments about people not receiving substance use specific education, and that is a problem. I know that there has been appreciable progress in the social work space to make sure that there is a nod to it, and in prescribers as well, more training now. This morning, I just got done twice annually for the last 8 years. I do the behavioral health foundational education for all the new nurses at our county hospital twice a year. And just, it's so critically important for me to just lay a little foundation right there to displace any biases that they have come about honestly, or misinformation they've come about honestly too. So critically important. That's my final holler into the mic. Final messages, Dee, then Terrence, and then Shelley's going to take us out with a goodbye.
Yeah, I don't. I'll go first. I don't think Dee's unmuted yet. So listen. That I think what you just said there is important. Donald. That even if we're successful in recruiting, millions of more individuals, who are, or hundreds of thousands of more individuals who are willing to dedicate their primary work to people with substance use disorders, we'll continue to need to across the spectrum of primary care and allied health professionals and social workers and others who are willing to be trained and learn and trained and educated on treating addiction and co-occurring disorders. So that's a part of NADEX mission as well, to not only help those who consider themselves addiction professionals, but the many other professionals who encounter the impacts of addiction on individuals, families, and communities. That matters. The bottom line is that addiction treatment, the addiction profession, is an honorable profession. And sometimes the stigma that's associated with addiction, even today, translates to those of us who've dedicated our professional lives to helping to make that issue better. And that's what we got to change somehow. We have to elevate the honor it is to help save lives and set people free. It's as important as anything that's out there. And so, in large ways and small and practical ways and symbolic ways, helping to elevate the profession as one of honor and dignity and great value is a goal we've got to reach.
Nicely done. And Dee, before you
Mhm.
lay some pearls on us, I wanted to just follow up with what Terrence said right there. I think it needs to be stated, we haven't spoken a whole lot about primary prevention, so I want to give a nod to my primary prevention professionals out there who've had such a huge impact on my practice, and are members of our associations as well, and state that prevention works, treatment can be effective, and recovery is real. Dee.
Yeah, I'm very conscientious of the time, so I will try and keep it short. But I just want to acknowledge that we talked a lot about licensed addiction professionals, and we really need to talk about our recovery coaches and our recovery coaches' importance in this, and how valuable they are with their lived and living experience. In Massachusetts, we 100% could not do this work without them, and we're moving that whole licensure into our Bureau of Substance Addiction Services. It is a reimbursable service through our Medicaid, so it is something that we are committed to, and I couldn't agree more with stigma. you know, even after 30 plus years of being in this field and being in recovery myself, the words that come out of people's mouth about what I do and who I serve is horrifying. And it is, we would never talk about anybody else like this. Everybody, you know, matters. Everybody that we take care of is somebody. They have favorite ice cream, a favorite pet, you know, and their life has value. And you supported the primary prevention. I do too. I also want to support those who are still are not committed to abstinence, and that they deserve the support and care and opportunities. And this is the only disease that we actually demand remission before you can actually get help. And that is problematic. So I'll just leave it there. So, but thanks so much for letting me join this conversation.
Thanks, everyone. Shelley, take us out.
Just wanted to say thank you so much to our panelists, to Sarah, Kelsey for joining us. What a great conversation. And I know that we could have probably gone on into deeper and deeper dives for an entire afternoon. You know, I just want to underscore a few things. One is that there's been just a ton of fantastic work that has gone on. I know sometimes we look at these numbers, and I know from being in this field for a long time, it's easy to kind of, you know, sometimes lose hope, but there is hope. And people are recovering every day. People are getting their lives together every day with the help of so many of you that are listening in on this conversation. And you all matter. The work that you're doing matters. And we really are a nation in recovery. And I think if we kind of work collectively and learn from each other, we can really continue to do wonderful things together and continue on the path forward. So thank you so much. Everyone will be getting an email with the resources we talked about. I know we didn't get to every single question. But feel free to reach out to us if there are need for additional conversations or questions. And we look forward to seeing you all again. Thank you, everybody.